Hi doing everybody, we're gonna start with the esophagus and differential diagnosis of dysphagia, which are we're gonna start with the achalasia, in which the lower esophageal sphincter fail to relax. On the other hand, scleroderma, in which the collagen replaces the smooth muscle of esophagus. Next is the Shatsky ring, lead to intermittent dysphagia. The other one is the Plummer-Vinson syndrome, which is associated with iron deficiency anemia and cytopenic dysphagia. The nutcracker or diffuse esophageal spasm with characteristic crucial chest pain, also very important. Herpetic esophagitis and the candida esophagitis are okay with immunocompromised patient. The squamous cell carcinoma and characteristic progressive dysphagia for solid and fluid. Zinger pouch and the halitosis may be used as a clue. A famous GERD, the classic symptom as heartburn, long-standing GERD may lead to palate esophagus, which is a pre-malignant for esophageal cancer. Very important entity of esophageal disease, the Mallory-White syndrome, related to retching and vomiting, and patient present with upper GI bleeding. Now let's move to the stomach section, and let's start with the acute gastritis or the erosive hemorrhagic type. Patient present with epigastric pain and upper GI bleeding. This is maybe due to H. pylori infection or maybe acid use. There may be excessive alcohol intake. The other type of gastritis is the chronic gastritis, or what we call atrophic gastritis, due to H. pylori and autoimmune cause. H. pylori also may cause the gastric ulcer in patient present with epigastric and food-related pain. On the other hand, duodenal ulcer occur due to increased HCl secretion, which occur in the enterogastritis and gastrinoma. And the classic example for gastrinoma is the Zollinger-Ellison syndrome. The tumor arises from the pancreas. Long-standing H. pylori and the atrophic gastritis may lead to gastric carcinoma, which are two types. The first one is the intestinal types arising from the damaged mucosa. In pathology, the adjacent intestinal microplasia is the key for diagnosis. Another type is diffuse type arising from normal gastric mucosa. And in pathology, the Singlet ring cell are characteristic for diffuse type. Treatment, just take it out. The gastric lymphoma is the most common site for extranodal non-Hodgkin lymphoma, and the majority are the B-cell origin. Treatment on the CHOP regimen, antibiotic, especially for maltoma related to H. pylori. The benign tumor, gastrointestinal stromal tumor, arises from an interstitial cell of Kegel, stem positive for CD117 and 34. Now let's move to the colon and start with the colitis syndrome. We're gonna start with the famous ones, the ulcerative colitis, many side effects, but the patient classically presented with bloody diarrhea. Life-threatening complication of ulcerative colitis, the toxic megacolon, the abdominal pain, distension, fever, and tachycardia. Having said that, ulcerative colitis must be differentiated from granulomatous colitis. Something can be morphic than the ulcerative colitis due to the ischemic lesion and recurrence. The next one is the ischemic colitis, which ranges from the simple mucosal and submucosal hemorrhage and edema to more severe pathological picture resembling inflammatory bowel disease, such as chronic ulceration, cleft abscesses, and pseudo polyp, to the most severe, which is transmural infarction with resulting perforation. Now let's move to next entity of the colitis, the pseudomonadal colitis, so-called C. diff colitis, following use of broad spectrum antibiotics such as Glenda erythromycin, and the offensive smelling diarrhea and fever, abdominal pain are the classic presentation. The microscopic colitis, patient present with a chronic watery diarrhea, may be collagenous colitis, or on the other hand, could be lymphocytic colitis. The last one is the virginal colitis. Inflammatory process affects segments of colorectum that are diverted from fecal stream following surgery such as colostomy. Now let's move to the very important polyposis syndrome, which are maybe neoplastic, which are two types. Actually, the tubular gland architecture and the villus gland architecture. The very important example of that is the FAB, which is the patient carrying that disease will develop cancer by the age of 40, so prophylactic surgery is recommended. Presence of chirpy is 100% predictive for presence of FAB. Gardner syndrome is FAB plus extracolonic tumor. On the other hand, Turcot syndrome is the FAB plus primary CNS tumor. The other thing is non-neoplastic hamartomatous polyp, and the example of that is the first Peptic syndrome, the hyperpigmentation mouth and beak. Second, the Crohn-Canada disease, the anomaly of epidermal tissue, the patient present with alopecia to the nail and pigmentation of the skin. Third one is the Cowden syndrome, hamartomas of ectodermal, mesodermal, and endodermal in origin, and there is increased risk of other neoplasms. Having said that, FAB resulted from what we call chromosomal instability. On the other hand, H and BCZ result from microsatellite instability, and both are pre-malignant and lead to colon cancer, which may be present on the right side or left side. On the right side, patient actually present with, or all patient present with anemia. On the other hand, patient with left side colon cancer present with a fresh rectal bleeding and sign of bowel obstruction. On X-ray, the apple core appearance is for left side colon cancer. Very important disease, diverticulosis, increase pressure area, such as sigmoid and sigmoid colon. Complication, diverticulitis, special form of colitis resembling left side appendicitis. The other complication of diverticulitis is perforation, life threatening. Now let's move to the small intestine, and let's start with the malabsorption syndrome, and let's start with celiac disease or gluten sensitive neuropathy. And the characteristic presence of anti-TTG antibody, highly sensitive and specific. On endoscopy, the scalloping of the small bowel. Dermatitis herpetiformis, note that 90% have GSE, but only 10 to 15% of celiac have the dermatitis herpetiformis. Tropical sprue, the recent travel to tropical region, is the key for diagnosis and treated with tetracycline. Weber disease, multi-system affection, arthritis, cognitive change, nystagmus, and on biopsy, the Trophorema Whippley has the PAS positive macrophage inclusion are diagnostic. Other cause of malabsorption may be beta lipoproteinemia, pseudoderma, amyloidosis, maybe blind loop syndrome, and distal ileal resection or bypass. Thank you.